So we are live now.
Thank you.
I'm starting the session.
हेलो
Yes, please. Mute
थोड़ा सा
everyone.
बस आप चेयर लेके बैठ जाना हाँ बस
Okay, so good evening to all respected faculty members and delegate members who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 171st edition of Happy Learning Masterclass webinar series in association with Bokaro, Deoghar, Dhanbad, Jamshedpur, Ranchi, Jammu and Kashmir. The theme for today's webinar is mixed bag. And the convener for today's webinar is Dr. Asha Jain. So let me introduce Madam. Madam has 32 years of experience in OB and gynec field, and Madam has Foxy Register Ultrasound Training Center, Colposcopy Training Center. Madam is currently Director of SMSA Hospital Raipur, Medical Director Cancer Prevention and Relief Society, elected member of Chhattisgarh Medical Counseling, Vice President IMA Chhattisgarh, and Madam's fields of interest are saving the uterus, fetal medicine, obstetric and gynec, ultrasound, critical care, and preventive oncology and colposcopy. So I welcome Dr. Asha Jain. The coordinator for today's webinar is Dr. Rekha Rajendra Kumar. Let me introduce Madam. Madam has 31 years of experience in gynecologic field. Madam is President-elect BSOG from 2023 to 2024. Madam has invited faculty in more than 700 state, national, and international conference. And Madam has also received various awards and felicitations. And Madam has more than 100 radio and television talks, 40 newspaper articles, all on women's health. So I welcome Dr. Rekha Rajendra Kumar.
Thank
And
you
as per the traditional course, I would like to start the session with lamp lighting session. Thank you so much, all respected delegate and faculty members, for your patience. Now I hand over the session to our convener, Dr. Asha Jain, madam. So over to you, madam.
Thank you, Nilesh. I welcome all the dignitaries, faculty, and delegates from Jharkhand and Jammu and Kashmir. And I also welcome Dr. M.C. Patel, sir, the director of this program. And this whole series is his brainchild. We all know him. And, sir, I hand over the mic to you for the formal welcome address.
Thank you, Dr. Asha. But due to some technical issue, my video is not visible. So, but I hope I am audible.
What happened?
Yes, sir.
Yes.
You're audible, sir.
Okay. So, it gives me immense pleasure to welcome you all to this 171th episode of Happy Learning Masterclass. And today, joining society, Bokaro, Dhanbad, Deoghar, Jamshedpur,
Unable to see
Ranchi,
your face.
Jammu, and Srinagar. So, I welcome Dr. Usha Nath, madam. She has kindly consented to be chief guest to bless the webinar. Of course, she is always with us in any of our academic activity. She always spare time for us to bless us. So, welcome Usha Nath, madam. I also welcome Dr. Shivani Jha, madam, from Dhanbad. She has also kindly consented to be guest of honor to bless the webinar. She is also with us always in any of our academic activity. Same way, Dr. Maya Verma, madam, from Ranchi. She is also guest of honor today to bless the webinar. Of course, she is always with us in any of our academic activity. So, welcome, Maya, madam. I also welcome learned speaker for today's very important talk related to placenta adherence syndrome or spectrum, Dr. Meeta Gupta from Jammu. And to chair that very important session, I invite three learned chairperson, Dr. Banita Sahay Madam from Jamshedpur, Dr. Ranjana Joshi Madam from Jamshedpur, Dr. Kiran Trivedi Madam from Ranchi. So all the three learned chairpersons
Is
are
the
going
problem?
to chair respective session.
Or
I also welcome
not audible,
join all the panelists.
neither
who
visible,
are,
not audible.
panelists today in reverse panel on documentation. They are going to ask question, and being a moderator, I will be answering. So I welcome all the learned panelists, Dr. Amita Gupta Madam from Jammu, Dr. Sehnaz Madam from Srinagar, Dr. Nigat Madam from Srinagar, Dr. Shashibala Singh Madam from Ranchi, Dr. Archana Kumari from Ranchi, Dr. Nivedita from Bokaro, Dr. Anupriya Pankaj from Bokaro, Dr. Gayatri Singh Madam from Dhanbad, Dr. Neha Jha from Dhanbad, Dr. Binod Agarwal from Jamshedpur, Dr. Arpita Gandhi from Devgar, and Dr. Priyanka Rai from Devgar. I also welcome Dr. Apurva Datta from Dhanbad. And I also welcome Dr. Suman Sinha from Ranchi, now President-elect for Vaginal Surgery Committee. She was in this series since long as a Master of Ceremony. Welcome again, Dr. Suman Sinha. I also welcome Dr. Asha Jain, who is convener in this series since long from Ranchi, and Dr. Rekha Rajendra Kumar from Bengaluru, President-elect Bengaluru Society. As a coordinator, she is also in this series since long, and all the President and Secretary of respective society who have joined this webinar, and all the delegates who have joined this webinar. So in era of COVID-19, when I started this meeting with 3 persons, and now I am happy to announce that now we are more than 7,000 plus member delegates as far as Happy Learning Masterclass family is concerned. And we usually go with any focus topic for discussion and one panel. So we have already completed 3 rounds of India, all over India, all the Society of Foxy, and this is our 4th round. And in this 4th round, we have made a little change in the module, and we are now doing reverse panel on very discussed focus topic. We discuss that topic, and panelists ask the question, and being a moderator, I the question. With this small remark, I welcome you all again to this 171th episode of Happy Learning Masterclass web series. Thank you very much.
Thank you, sir. May I have Dr. Suman CV, please? So I would like to welcome once again to this Happiness Masterclass, Dr. Suman as a convener for this program. She is a senior consultant guidee at AHIVF and Infertility Center, Ranchi, Director, Advanced Care and Maternity Center, Ranchi. She is the chairperson-elect, Vaginal Surgeries Committee, FOXY, 24 to 26. She has an experience of over 30 years, and her has been the chief of Medical Services and HOD Obstetric Gynae at CCL Hospital, Ranchi, a subsidiary of Coal India. You all know her so well, held many positions, and she is from Jharkhand. I'm sure you all know her very well. So I welcome you, Dr. Suman, to this webinar. And as a convener, I would like you to say a few words.
Thank you, dear Asaji, for your very valuable and very nice comments regarding me. So I'd like to wish good evening to one and all, and Johar from Ranchi. I'm honored and really privileged to be once again on this very illustrious platform. My regards and gratitude to the program director, our own Dr. M.C. Patel, sir, for his unwavering support and patronage in getting me elected as Vaginal Surgery Committee chairperson. I'm equally thankful to my Happy Learning team, to begin with Dr. Sneha Bhuar Madam, Dr. B. Kalpana, Dr. Jyoti Banglowala, Dr. Rekha Rajendra Kumar, and dear Asa Jain, for believing me unconditionally. Today, I'm really very happy that entire Jharkhand society, along with Jammu and Srinagar societies, has the opportunity to be selected for this today's webinar. I welcome our honorable chief guest, patron of Ranchi Society, Dr. Usha Nath Madam, whose strong dedication and commitment always inspires all of us. I next welcome our guest of honor, Dr. Maya Verma Madam, who is my mentor and guide. And next, I welcome my colleague and my batchmate, a great athlete from Patna Medical College, Dr. Shivani Jha. I'm really thankful to all to the chief guest and our guest of honor for sparing your valuable time to be with us. I also welcome a luminary speaker, Dr. Meeta Gupta, who will be speaking on a very relevant topic on placenta accreta syndrome. And only to be chaired by Dr. Banita Sahai, past president of Jamshedpur Society, Dr. Ranjana Joshi, she is also past president of Jamshedpur Society, and my dear Dr. Kiran Trivedi, past secretary of Ranchi Society. It will be followed by much awaited panel on documentation, which will be brilliantly moderated by our MC Patel, sir. The expert panelists from entire Jharkhand and Jammu and Srinagar are there. To name them, Dr. Amita Gupta, Dr. Shahanaz Tang, Dr. Nikhat Firdaus, Dr. Sashi Bala Singh, Dr. Archana Kumari, Dr. Nivedita Datta, Dr. Anupriya Pankaj, Dr. Gayatri Singh, Dr. Neha Jha Priyadarshini, Dr. Binod Agarwal sir, Dr. Arpita Gandhi, Dr. Priyanka Rai, and Dr. Apuru Kumar Datta. Thank you, Nilesh ji, and the entire Corona Remedies for supporting us unconditionally. I wish my best wishes for this webinar, and also to Dr. MC Patel sir. We see him as our next president, Foxy. So thank you everyone for giving me this opportunity.
Thank you. Thank you, Suman, for spending time. Of course, you are always a part of Happy Learning Masterclass family. So welcome again. Thank you.
Thank you so much, sir.
Thank you, Dr. Suman.
Thank you so much.
Nilesh ji, may I have the CV of our chief guest, Usha Nath ma'am? So, it's a great privilege and an honor to welcome on this platform Dr. Usha Nath ma'am. She has so many degrees: MBBS, FACOG, ASCCP, MBS CCP, ISCCP India, IGCS, ISO, and a guy. She is the medical director and chief consultant obstetrician and gynecologist at Nath Hospital, Kadru, Ranchi. Senior colposcopist, Women's Cancer Prevention and Colposcopy Center, Ranchi. Past president, Ranchi Obstetric Gynec Society, patron Ranchi Obstetric Gynec Society, and she has authored a book on rules and regulations of ROGS for standard management of society. Her work and interest, cancer cervix, caught her attention in the beginning of her professional life, and she returned to India after being 32 years abroad to work in prevention of cervical cancer among women who are disadvantaged. Her long commentary for her MRCOG book in 1973 was Prevention and Management of Precancer Cervix. She opened first colposcopy services in UAE, Ranchi, 2001, and free colposcopy examination for needy women in women's healthcare camps. She has contributed a chapter to colposcopy in gynecology, PPT on nightmarish Dilemma of Obstetrician in Labor Room, and contributed several articles, and has also developed a simple colposcopy training course. In research, her relationship of cesarean section in relation to maternal well-being, original research study on colposcopy in conjunction with VIA, feasibility as first-line screening in LRDC, and comparison of incidence of cervical dysplasia in urban and rural population by mobile colposcopy. Welcome, ma'am. I'm really honored to read the CV because from the very beginning of my career, I also got caught up with colposcopy. So we would really like you, welcome you, and would like your blessings for this webinar.
Oh, what to say, Dr. Asha? I'm really touched with your introduction of myself. So thank you very much. And now I say thank you, Dr. M.C. Patel, for inviting me to be the chief guest of this Happy Learning Masterclass edition 171. I sincerely feel this to be a great honor for me. I am really greatly inundated to be present and participating in this academia of perseverance of learning. Dr. M.C. Patel has been a long-term friend, and I have known him since 2013 when I was president of ROX, and invited him for a medico-legal importance in obstetric and gynecology session. Actually, I didn't know him then, but Dr. Usha Rani suggested his name that he is very expert in this field. So when you talk to him, he may accept your invitation. And I really admired him greatly that with one phone call, he accepted my invitation and came from Gujarat to Ranchi. And I'm really honored to have known you, Dr. Patel. The topic of this webinar has caught my eyes because the placental adherent spectrum and reverse paneling upon documentation are really very important for the field of obstetric and gynecology. And this is worthy of revision and re-revision. They have far-reaching consequences in our field. And I remember that it has a lot of effect on the maternal mortality, maternal and fetal mortality, and the period. And therefore, it is very important to know. And also because the incidence of this placental adherent spectrum has increased tremendously recently, probably because we are using instead of in our days, we used to use CapCut. Now we use Vicryl, which takes long time to be absorbed. Then also because the incidence of cesarean section has increased tremendously. So probably they are all contributing to this. And I welcome all the participating faculty and all Dr. Asha Jain, Suman, Kiran, Archana, and all of them. And I'm really also happy that for the first time, I'm going to be associated with Jammu and Kashmir Society and will listen to them. So I'm anxiously waiting to hear them. Also, at the end, again, I want to give thank you to Dr. Patel, and I wish him a lots of good wishes and luck for your election. But I have a faith that you are going to be our president in near future. Thank you very much. and welcome to all. And I'm really honored. Thank you.
Thank you. Thank you very much, Usha Nath madam. I am always blessed with your blessing. And just you mentioned when I visited Ranchi in 2013 and then onward and before that also, I have visited
Yeah.
Ranchi so many times. Now I have
Yes.
stopped counting for how much time I have visited.
Yes,
So,
true.
because
You are one of us. You
yes,
are one of us.
previously I was just you mentioned Dr. Usha Rani madam. We are working in National Medical Organization and Karuna project. All the Ranchi people are knowing that project very well. Karuna project for orphan child, I mean children. She was looking after
Yeah.
that since years together. And whenever I have visited Ranchi, I have always visited Karuna because when I was national president of NMO, under me, this Karuna project was doing very well. And at that time, we had were about 54 children in that orphan house.
Oh,
And we are now government recognized organization. And whenever we get eligible couple, then we make children from that orphan house to them for adoption also. So from newborn children to some younger children are with us in Karuna project. Dr. Usha Rani madam has given her services for years together in that very project. And
very true.
yes, and for their nourishment, for their education, and when they grown up for their job and marriage also we take care as far as children living there in Karuna project is concerned. So Ranchi is close to my heart as far as all these activities
Thank
are
you.
concerned. So
Thank
thank
you.
you, Usha Nath madam. And
Yeah.
many times your mere presence is enough to have us inspiration to do our so many of activities, social activities, as well as this type of academic activity. So thank you very much, madam, for sparing time.
Thank you.
Yes.
Thank you.
Thank you, sir. Thank you, Usha ma'am. And Dr. Rekha, would you please introduce our next guest of honor, Dr. Shivani?
Yeah. Thank you, Dr. Asha. Madam Dr. Shivani, we are so happy to have you and we are very proud to share the platform with you. Madam is a very senior obstetrician gynecologist. Her designation is she is the medical director of Sri Krishna Matri Sadan Satvik IVF and she's from Dhanbad. Madam was the vice president of ISAR, that's from Jharkhand. Past president of Foxy Dhanbad branch, again vice president of IMA from Dhanbad. Madam has lots of awards and accolades to her credit as Unsung Hero Award of Foxy, Doctor of Millennium Award from Indian Medical Association, Champion of Champions Award by Manyata, as well as Foxy Appreciation Award. There were many very prestigious awards. She also has many publications to her credit and her special interest is on high-risk pregnancy and infertility. We are extremely fortunate to have you here, Shivani madam. We would like to listen from you.
Thank you, madam. Good evening, everyone. I'm really honored and pleased to be a part of such a prestigious webinar, which is brainchild of the respected Dr. M.C. Patel, sir. It's delight that all the society of the Jharkhand and Jammu and Kashmir coming together to discuss a very nightmare of the obstetrician adherent spectrum placenta and also learning some silent points of the documentation for the medico-legal expert from the Dr. M.C. Patel, sir. I am really thankful to the organizer for giving me this opportunity and looking forward to a great session. And I am always with the Sir M.C. Patel, sir. Really, we want to see you as our future Foxy president, sir. Thank you very much. I am really feeling very honored to be part of this webinar.
Thank you very much, Shivani madam. You are always with us, of course. And thank you for sparing time to bless the webinar.
Thank you, Shivani madam, for your words of wisdom. We are happy to hear you.
Thank you. Thank you, Rekha. May I have Maya ma'am CV, please? So I welcome Dr. Maya Verma ma'am, who's the retired professor and HOD of Obstetrics and Gynae, RIMS Ranchi and Haldwani Medical College, Uttarakhand. He was external and internal examiner for undergrad, PG, PhD, and IGNOU. She is also the past president of Ranchi Obstetric Gynec Society. She is working as a senior consultant and CEO of her own nursing home in Ranchi, which is called Upchar. This is a really short CV because I don't think Madam needs much of a CV. Dr. Suman has already said that she is her mentor. So over to you, Maya ma'am. We would like to hear your words of blessings.
Thank you, Dr. Jan. I have nothing more in my bag to say that I got this, I got that, I wrote this and that, but I was devoted. I'm still devoted in my subject in Obs and Gynae, and I'm respected by my juniors, my students till today, and very happy by seeing them very high posts that the working, most of them, not most of them, many of them working here in very high posts in big hospitals. It gives a tremendous pleasure that I was here and I did good things as said by these new doctors. They are not new these days. They are very quite senior. So I have not to say many things about me, but I have to say words for Dr. Usha Nath, Dr. Usha Rani, Dr. Patel. Dr. Usha Rani has brought me to that Karuna about which Dr. Patel has said so many things, and a very little effort is by me to this Karuna, and very happy. This Karuna is very near to my house. So I often used to go to that place and see the kids and the caretakers also. So it is very next to me. And Dr. Patel, there is no word for telling you, for saying you about you. You whatever thing, what a tremendous word, happy learning. This will remain immortal in our Foxy. Till Foxy will remain, and this will continue. I wish this happy learning should continue till this Foxy remains. So many congratulations and thanks to Dr. Patel. Where has your face gone? I'm not able to see you. So, so I have dearth of words for saying the good words, the complimentary, the many good things for Patel, for he deserved all these things. He is the symbol of India. He roams all of the states of the Indians. So all his states are like his own house. And he is spreading the knowledge all over. This knowledge, spread of knowledge will continue. I wish it should continue. And it is teaching not the newcomers, but is making aware for the newer things to the senior persons also. So thank you, Dr. Patel. And the subject, this placenta accreta syndrome. I do remember my earlier age when we faced sometimes the retained placenta. And it is not separated spontaneously with, I can say the nocho placenta ko, or एक piece by piecemeal. And sometimes the patient bleeds and we used to control it by giving uterine packing. Now such a dangerous thing, we dealt without having proper knowledge. God was helpful for that. Those patients didn't die and no mortality, morbidity. And God has blessed us with this knowledge. But now this placenta accreta syndrome is becoming so popular, and is covered in many seminars and CMEs. And we are also knowing this knowledge of this invading the bladder, the rectum, the how to, and this spreading bad thing of this placenta. But whatever difficult it may be, but the teaching about this and the researches, the diagnostic process, the timely diagnosis, the assessment of the time of delivery, the proper time, and the one more thing, the having the help of the other departments also has though it is very difficult to face this condition, but it has reduced the morbidity and mortality. So thank you, the person who has selected this topic. I think Dr. Patel must have selected this topic, placenta accreta syndrome. And every time you read it, you will feel that it is something new, and everyone has to learn, and become too familiar with this subject. So thank you to all of our colleagues, Dr. Patel, and making me the part of this seminar. I always attend this seminar wherever whether Ranchi is included or not. I do attend the seminar, this happy learning. Thank you, everyone. I will not take much of time. I have already taken the time. So sorry for that. Okay, sir.
Thank you. Thank you, Maya Madam, for sparing time to bless us. Thank you.
Okay.
Thank you. Thank you, Usha ma'am, Shivani ma'am, and Maya ma'am for blessing this webinar. With this, I announce the closure of the inaugural session and over to Dr. Rekha to introduce the chairpersons of this evening. So we start the
Oh, yes.
session.
Oh, yes.
Yes, sir. Over to you, Dr. Rekha.
Yeah, thank you, Dr. Asha. Mr. Nilesh, I would like to have the CV of chairpersons. First is Dr. Benita Sahai. Yeah, thank you, Mr. Nilesh. Dr. Benita Sahai, madam, I request you to chair this session of the prestigious talk by Dr. That is on the placenta accreta spectrum by Dr. Meeta. Coming to the CV, that's a brief CV of Dr. Benita. Madam is highly qualified consultant gynecologist. She did her DGO from Ranchi Medical College Hospital, from Ranchi University, MBBS again from Ranchi, correspondence course in ultrasonography as well as cancer cytology of the cervix, correspondence course in gynec endoscopy surgery and in the Endoscopic Research Institute of Kolkata, training course on digital video colposcopy also madam has completed, and has done her IVF course from Bloom Fortis under Dr. Rishikesh and Dr. Nandita Palshetkar way back in 2012. She's assistant professor of MGM Medical College and Hospital in Jamshedpur from 2004 till now. She has a lot of publications as well as a speaker and lecturer, has given lectures in many of the national and international forums. Welcome, Dr. Benita Sahai, madam. We request you to chair this session. Yeah, Mr. Nilesh, please show me the CV of second chairperson, that is Dr. Ranjana madam. Dr. Ranjana Joshi is MBBS MD from CMC Vellore, MD from Varanasi, Banaras Hindu University, laparoscopic, as well as she's fertility specialist. Her present designation is she's head of the department in obstetrics gynec department of Tata Tin Plate Hospital, Jamshedpur, as well as president of Jamshedpur Obstetrics Gynec Society. She was the ex-secretary of the same society. Lot of publications which were presented in AICOG as well as in journals. Madam has special interest in gynec oncology, high-risk pregnancy, minimum invasive surgery, as well as robotic surgeries. Welcome, Ranjana madam, to this forum. Yeah, thank you. Dr. Kiran Trivedi, madam, again chairperson. Welcome you, madam. Madam is the additional professor in the Department of OBG in Ranchi Hospital, Ranchi City, organizing secretary of FOXI for UA conference in 2022, secretary of Ranchi OBG Society from 21 to 23, ex-joint secretary of Ranchi Obstetrics Gynecology Society, ex-treasurer of the same society. Madam is life member of IMA, FOXI, ISOPAR, and Indian Fertility Society. And she has a lot of awards to her credit. One important is the MS Signature Award, and madam has a lot of national and international publications as well as the presentations in the international conferences. Her special interest is on minimum invasive surgery as well as vaginal surgeries. Again, we welcome you, Kiran madam. All the three chairpersons, Dr. Benita, Dr. Ranjana, and Dr. Kiran madam, to chair the session and to take the proceedings forward. Thank you.
Thank you, Dr. Rajendra Kumar, madam. Rekha Rajendra, for your kind introduction.
Thank
Today,
you.
it's a proud privilege to become a part of this prestigious webinar where the program director is Dr. M.C. Patel, who has made this a very happy learning of this all the important topic. And I show my gratitude to him for continuing 171st of the web series of this webinar, and he must be reaching the second century very nearly. I also greet both the convener, Dr. Asha Jain, and Dr. Dr. Suman Sinha, and coordinator, Dr. Rekha Rajendra Kumar. I show my regard to Dr. Usha Nath Madam and Dr. Maya Verma, who are great teacher and head of the Department of Ops and Gynae, Maya Madam, as she has told very nicely that learnings has been made very happy, and it's a very complimentary name was given to this webinar. Now I will expect to get the CV of Dr. Meeta Gupta, who is going to speak on a very important topic, that is placenta adherent spectrum. So kindly give me the CV of Meeta Gupta, madam. She is the Associate Dean of and Professor of Department of Ops and Gynae, AIMS, Vijayapur, Jammu, and she is a member of Safe Motherhood Committee also, and past secretary of Jammu Menopause Society. She is also a winner of Women Health Researcher Award, an advanced course in the medical education. Teacher for the last 18 years, the special interest in adolescent health and high-risk pregnancies. Many publications to her credit. So the floor is your Dr. Meeta Gupta, who is going to talk over the adherent placenta spectrum, a very important topic in which there is a wide range of the placenta, that is increta, percreta or pancreta, and which is a very dangerous condition which the obstetrician goes through, and even sometimes we have to go for the cesarean hysterectomy. So please, floor is your Dr. Meeta Gupta.
Just a second, ma'am. Dr. Ranjana, ma'am.
Yeah.
If you would say something about the topic in detail.
Thank you very much once again. Thank you to Dr. Asha, Dr. Rekha, Dr. Patel, Dr. Suman for giving me an opportunity. And now, without any delay, I just like to say a few words about the topic, and it is really, really relevant to all of us. Obstetric hemorrhage is one of the leading causes of maternal deaths in developing nations like India, and abnormal placentation has now emerged over the uterine atony as the leading indication for peripartum hysterectomy. However, these placental abnormalities rarely get detected before delivery. Placenta accreta spectrum, formerly known as morbidly adherent placenta, refers to the range of pathological adherence of the placenta, namely placenta accreta. Morbidly adherent placenta is one of the devastating complications, as we all know in our practice. It is characterized, of course, by the attachment of the placental villi directly to the myometrium, which may extend even to the uterus wall or the surrounding organs. It is my great pleasure and honor to welcome Dr. Meeta Gupta, as she has already been introduced, for enlightening us, all of us, about the types of adherent placenta spectrum and their symptoms and management. Welcome, Dr. Meeta.
Thank you so much, ma'am. Thank you, Banita ma'am and Ranjana ma'am, for that kind introduction. At the onset, I would like to thank MC Patel sir, Asha Jain ma'am, the convener, and Suman Sinha ma'am for the great conveners being, and the coordinator Rekha Joshi ma'am for giving me this opportunity to be at this platform. So I think so my screen is visible, ma'am. Can I start with the permission of my chairpersons?
Yes, Visible.
Okay. Thank you so much, ma'am. Thank you,
Yes.
ma'am. Thank you, ma'am. So as the word placenta adherent syndrome, placenta accreta syndrome, there are so many names, but this is the most dreaded that any obstetrician would meet in their careers. So it is 2 a.m. in the morning, gravida 3, para 1, 24-year female, 37 weeks, 3 days, presented with leaking per vaginum. The leaking was slightly bloodstained. There is a history of preterm cesarean 3 years back, followed by a spontaneous abortion, which was followed by a suction and curettage 1 year back. There was no antenatal visit, and the patient had only a third trimester ultrasound in which a single live intrauterine pregnancy was seen with placenta posterior and low lying. So the obstetrician took the patient for emergency cesarean. The baby was delivered, and despite repeated attempts to remove the placenta, it could not be removed. And what followed was that there was a torrential bleeding, and it was diagnosed to be an adherent placenta. It was 2 a.m. in the morning with no blood arrangement, and the anesthetist was a new person. No backup was there. Baby was saved. Mother lost the battle. The obstetrician was thrashed. The hospital was damaged. So where did we go wrong, or what was done wrong? So to define, a placenta accreta syndrome or a placenta adherent syndrome is our varied name for a condition in which the placenta is abnormally attached to the uterine wall, and this is due to the invasion of the chorionic villi within the myometrium. It was Lee who had proposed this name way back, and so that the different names that were prevalent at that time would all come under this syndrome, that is the placenta accreta syndrome. If we look at it was initially started with placenta accreta, then formally changed to placenta accreta syndrome, in which we find an abnormal placental implantation, or the adherence was so firm, and this was further classified on the depth of invasion into the myometrium. We all are worried. The obstetrician, the family, the patient, everybody is worried once the diagnosis is made, because we all have a feeling of helplessness regarding the outcome of the pregnancy. There is uncertainty regarding the outcome of pregnancy, the fetal and maternal mortality and morbidity. Pregnancy, which is a beautiful experience for the mother, becomes altered with a very traumatic experience. The mother, we cannot give any assurance regarding the outcome of the pregnancy, and this all adds to emotional distress to everybody. Why we all are worried is because it is a life-threatening for both the mother and the baby, as it is associated with torrential postpartum hemorrhage, which result due to non-detachment of the placenta from the myometrium. Emergency hysterectomy is required. With that, associated adjacent organ damage may be there. And as we all know, it is associated with preterm delivery, because every diagnosed PASS patient requires early intervention. Everybody is talking that there is abnormal placental attachment, but what exactly is abnormal? In a normal pregnancy, after delivery, the placenta separates and is easily expelled after delivery. But in PASS, there is an abnormal attachment of the placenta to the uterine wall. If you look at the figure 1, there is a light yellow color, a light pink color that is present. That is the protective layer from where the placenta separates. But in these patients, this protective layer is absent. So the placenta invades into the myometrial tissue. The spectrum includes the entire placenta accreta to increta and percreta, and they are further graded according to the invasion of the trophoblast into the myometrium. The grade 1 is the placenta accreta, in which it is only the invasion of the placenta is only up to the superficial air of the myometrium. In placenta increta, that is grade 2, the placenta invades into the myometrium and may sometimes reach up to the external layer. the placenta percreta is the most dangerous, and that is where it will invade through the myometrium and reach up to the uterine serosa. If we look at the FIGO classification, the FIGO classification of grade 2 and grade 3, that is the increta and percreta, are also known as the abnormally invasive placenta percreta spectrum. Grade 3 is further divided into 3A, 3B, and 3C. 3A, where the placental invasion up to the uterine serosa. 3B would be an invasion of the urinary bladder, and 3C would be adjoining pelvic organs. Now that we know the definition, we will be discussing what are the risk factors in which we have to look for these PAS patients. Any history of prior uterine surgery, that is cesarean section, operative hysteroscopy, any suction evacuation, surgical terminations, or an myomectomy are all a risk factor for these patients. Any endometrial ablation procedure, maluline removal of placenta, and any advanced age of the mother with associated history of smoking or arterial hypertension, all are risk factors for any patient developing PAS. Multiple pregnancy, previous placenta previa, and especially in vitro fertilization, and that too with cryopreserved embryos, these are the patients which have a 4 to 13 risk of developing PAS. Why we all are so afraid is because the increasing in cesarean section rates from 10 to 40% in the last 40 years has led to a 10-fold increase of these disorders. And it is documented that every increase in cesarean rate, the incidence of PAS may land from 1 cesarean, increasing the chances by 4.5%, whereas if 4 or more cesareans, the increased chance of PAS would be about 44%. Now coming to the pathophysiology, it is said that once any iatrogenic defect is occurring, this causes a defective decellularization of the endometrial myometrial interface, and this scar tissue causes abnormal deep trophoblastic infiltration. In IVF, it is said that a different hormonal milieu during the implantation and the placentation phases is required, which promote deep trophoblastic invasion, resulting in placenta accreta syndrome. This could either be because of the elevated serum estrogen, which causes increased trophoblastic invasion into the myometrium, or maybe because of the lower serum estradiol and the thinner endometrium. But we all have to understand that this defective Nitterbusch layer causes placental blood supply from a spiral artery to convert into deep radial or an arcuate artery, which causes high velocity blood flow in the uteroplacental flow. And this is on color Doppler appears as hypervascular. But the most prominent theory that everybody agrees as per the 22 guideline is that following a uterine surgery, the scarring or the healing process leads to localized hypoxia, and this results in abnormal vascularization, which leads to defective decellularization and allows trophoblastic invasion into the next pregnancy. Bai Lee et al. Has also told us that a predictive scoring model for PPH in PAS syndrome is there, in which he has said that if you take the features of maternal age, antepartum hemorrhage in this present pregnancy, any chance is any presentation being non-cephalic of the fetus, placenta previa type, placental location, uteroplacental vascularity, and multiple lacuna. If we score according to this criteria, then we can safely predict, and the patient having a score of more than 5/10, we can easily predict that these patients will have severe PPH with a sensitivity of 81% and specificity of 77%. But this was done in a very small study, very small group of patients, and larger randomized trials are requested to be done to validate this study. So how do we diagnose this patient? Is it on a clinical criteria or an imaging of an ultrasound or MRI? Do we do the biomarkers or a histopathological criteria? The clinical criteria is most important, but we have to understand that no established clinical diagnostic method is available. The patient may be completely asymptomatic, which can be detected on OT table, or may have some symptoms of bleeding during pregnancy, but a high level of clinical suspicion is required. Sometimes at the time of surgery, once we open the abdomen, there are few steps that we can by which we can identify these patients. The first step is that on opening the abdomen, if we look at the external surface, there is a lot of bluish or purple appearance due to increased vascularity on the serosa. This should warn us. The second step is after delivery of the fetus, if we pull traction on the umbilical cord, this causes dimpling on the uterine wall. This is known as the dimple sign. This is the second feature. And the most diagnostic would be if we do not identify these patients even after step 1 or step 2, would be that if you do a gentle digital exploration to separate the placenta, we do not find any cleavage pain. These are the clinical criteria during perioperative findings. But the mainstay of the diagnosis would be an ultrasound. In the first trimester, a transvaginal sonography would be the best, but later in second and third trimester, a 2D or a 3D ultrasound with Doppler would be diagnostics. Please remember that ultrasound is the first line of imaging tool for screening and diagnosis of these patients. It has to be performed by a skilled operator because sometimes some scanning conditions like too full or too empty a bladder, the ultrasound equipment or the gestational age of the pregnancy may hamper or may create problems in the diagnosis of placenta accreta syndrome. But what is most important for us to remember is that any patient who at 18 to 20 weeks, once we are getting a fetal anomaly scan, shows that the placenta is anterior and there is a history of previous uterine surgery, always refer this patient to a specialist endocrinologist, to a radiologist to diagnose these past syndrome. Coming to MRI, we have to understand that this is the second line imaging tool. It can accurately stage the extent of the disease as well as the depth of the invasion and the lateral extension of the myometrial. This is of use especially in unfavorable placental location or if the mother is obese with high maternal body mass index. But we have to understand that MRI can never replace ultrasound. MRI, even though being less operator dependent, is associated with very high cost and has limited access to people, has limited access to equipment, and an expert radiologist is required. So this makes it an impractical screening tool. Coming to biomarkers, should we get it done? Literature shows that at 11 to 12 weeks, the HCG or free beta HCG levels are decreased and PAP-A, that is pregnancy-associated plasma protein levels, are increased. And in second trimester, both the serum beta HCG and alpha fetoproteins are increased. But no evidence is present in literature for us to say that this biomarker can be used to screen past patients. Histopathological criteria is the gold standard. So pathologists should be the team for the should be a part of the multidisciplinary team that handles these patients. The main criteria used for diagnosis is the absence of decidual or netterbush layer between the tip of anchoring villi and the superficial myometrium. So now that we have diagnosed these patients, what next? So the management strategy would be, we have to avoid any pelvic examination as well as avoid vigorous physical training. Patient has to be counseled to deliver in a hospital with blood bank facilities as well as massive transfusion protocols. The obstetrician has to decide whether we go for an early elective cesarean or we give the patient a risk of neonatal prematurity. So both these things have to be clearly discussed with the patient to decide for the management. A tertiary center is required for the delivery of these patients because we have access to subspecialists as well as critical care facilities. The team members would be a maternal fetal medicine people, experienced pelvic surgeons, pulmonary neonatologist, skilled nursing team, blood bank team, the anesthesia team, intensivist, urologist, and if required, an interventional radiology. It is always said that a multidisciplinary tertiary care center treatment improves the outcome of these patients. So the management strategy involves delivery before onset of labor, avoidance of placental disruption, and a multidisciplinary team management. So when to deliver a multidisciplinary tertiary care center treatment improves the outcome of these patients. So Dr. Gayatri, can we please mute you? Delivery before onset of labor, avoidance of placental. So when to deliver these patients after diagnosis, please remember that we have to deliver these patients between 34 to 36 weeks, and antenatal steroid prophylaxis is required. The patients who do not have any associated complication of prior history of prior preterm, no vaginal bleeding in present pregnancy, no preterm rupture of membranes, and no uterine contractions may be taken up till 36 weeks. Whereas if any of the above complications are present, the patient has to be delivered around 34 weeks. 34 to 35 weeks pregnancy-related hysterectomy with placenta in situ is what is recommended by the ACOG. So at the time of operation, intraoperative management would require an access to large bore IV cannulas for the patient, an arterial line for invasive blood pressure monitoring. Pneumatic compression devices should be used as hemorrhage, blood transfusion, and prolonged surgery all cause increased chances of deep venous thrombosis. Patient's volume expansion has to be taken care of. And if we have the facility of intraoperative ultrasound to clearly outline the edges of the placenta and safely deliver according to the placement of the uterine incision is what the guidelines tell us. So anesthesia, it could be regional, but we should have the facility to convert into general if the requirement is there. The skin incision is preferably vertical to give us a better access, but it can be a large transverse incision if the surgeon is an expert, because the transverse incisions, they heal better and also are cosmetically better. The uterine incision may be given in a way so that the placenta is avoided. So classical cesarean may be offered to the patient. After the delivery of the fetus, we have to proceed further with the primary cesarean hysterectomy, or another, that is the conservative treatment, which involves placenta being left inside and closing the uterus, followed by 24 hours later by the experienced surgeons to be followed by expulsion of the placenta. But this conservative treatment is associated with a lot of several complications like massive hemorrhage, infection, sepsis, DIC, and ultimately hysterectomy. At present, literature says that there are no randomized controlled trials or any well-designated prospective observational studies have been done to compare hysterectomy with conservative treatment for any type of past disorder. So it is left for the surgeon to decide for the treatment modality. We have to understand that the pregnancy-related hysterectomy is the gold standard. But is pregnancy-related hysterectomy same as any other hysterectomy? Because we have to do all the clamps, we have to ligate all the 4 round ligaments, and then to the ovarian ligament, and then the uterine vessels, and then the cardinal ligament. So is anything different? And the answer is yes, it is different, because the vascularity, uterine vascularity is highly increased. The tissue edema is present, as well as it is associated with a lot of fragility. So handling of the tissue is very difficult. The uterus is enlarged, so manipulation and overall visualization of the pelvis is harder. The normal anatomical relationships are altered, and the closest structure that is present are the ureters, which are tortuous and distended with significant hydroureter. But steps should be taken to prevent any injury to these ureters. Now, whether to go for total or subtotal hysterectomy, the goal is always a total hysterectomy, because if we leave the cervix, we have to go for regular cervical cytology to look for any risk of malignancy later developing, as well as we have to understand that cervix may be a cause of post-operative bleeding in some cases. So ideally, we have to go for total hysterectomy. But if we think that hemostasis is a problem, then sometimes the surgeon may go forward for subtotal hysterectomy. But ovaries have to be preserved in all and fallopian tubes to be removed, as this will reduce the chances of ovarian malignancy. The literature says there is a terminology known as delayed hysterectomy, in which the fetus is delivered, uterus is closed with placenta in situ, and abdomen is closed.
Please mute everyone.
So after we have closed the abdomen, a planned hysterectomy may be performed maybe 3 to 12 weeks in the postpartum period. The rationale is that the uterine perfusion as well as the vascularity of the placenta are reduced. So a delayed hysterectomy is less risky, but this is usually practiced in areas where the surgeon has limited experience, and literature has showed no benefit as compared to cesarean hysterectomy patients. What are the preoperative measures or peroperative measures we can take to reduce the morbidity of the patient? One of the features is application of intra-arterial occlusion balloon catheter placement, that is also known as prophylactic endovascular balloon catheters. In this, a balloon catheter is placed via both the iliac arteries. This causes blockage of these arteries, so reduces the intraoperative blood loss, so better vision, and the surgeon is able to operate in a clearer field. But it is associated with high complication rates like vessel rupture, thromboembolism, damage of the pelvic structures, as well as disturbance of blood supply to the lower limbs. Whether we should apply ureter stents in all, the literature advises against this, because this is used only to prevent injury to the ureters, and not every patient improves with this. This has to be individualized according to the expertise present as per the center. What is advised to everybody in all these patients is that utrotronics should be avoided, because with the use of utrotronics, the placenta may be there may be partial placental separation, leading to severe PPH at the initial start of hysterectomy. So the entire procedure for the surgeons becomes problematic. Tranexamic acid, as per the data, randomized trials have shown a very big beneficial effect by the use of tranexamic acid. So this should be advocated in all patients. Another entity is a uterine artery embolization. This is a minimally invasive procedure that is done by the interventional radiologist. He, under fluoroscopy, guides a catheter and uses small gels, that is known as embolus, to block the blood supply of the ureters. So it may be useful in patients having PAS, but this is of limited use because we need an interventional radiologist at our centers. What has come new is that a triple P procedure, that is perioperative ultrasound localization of the entire edge of placenta, followed by pelvic devascularization, in which we may use preoperative placement of intra-arterial blood catheters, balloon catheters, and there should be no attempt to remove the placenta after closing the uterus. After delivery of the baby, the uterus is closed and directly proceed to hysterectomy. This is what the guidelines tell us. In the post-operative management, patient has to be immediately shifted to ICU with continuous monitoring of blood pressure, pulse rate, respiratory rate. The patient has to be watched for any rebleeding episodes. The hypoperfusion and subsequent organ ischemia, renal and Sheehan syndrome has to be looked for, as well as these patients have to be mobilized early with use of compression devices so that the thromboembolic complications are markedly reduced. The deadly Ds of Akrita syndrome are delay in the referral, delay in the cesarean, that is the patient lands in emergency instead of doing an elective, and a delay in the decision to proceed to hysterectomy in cases of emergency. There is a deficiency in the time availability because of extensive adhesions. There may be a deficiency of blood and blood products, deficiency or inavailability of ICU beds, and the deficiency of multidisciplinary team. These are the deadly Ds of a CRETA patient, which we have to take care in case we are dealing with these patients. So the first case in which we had lost the mother, what could have been done better? The patient should have been taking regular antenatal checkups for early diagnosis. She should have been taken an elective cesarean section with a multidisciplinary approach, and the ICU care should have been there. So please remember, the expertise and aptness of the surgeon matters here. Every patient should be preoperative diagnosis should be made. Anemia correction, patient counseling is foremost and most important for the patient and the family. Patient should be under regular follow-up, should be delivered in a setup which has the multidisciplinary team where a cesarean hysterectomy be taken, and all these measures can save lives. Coming to the preventive, please remember that this is an iatrogenic 21st century disorder. We should avoid vigorous curettage. Patient should be given good trial of labor so that the primary prevention of cesarean is decreased. 2-layer of uterine suturing should be practiced. The tissues should be handled very carefully with not too much of trauma, and any chances of postpartum endometritis should be taken care of. So just to recapitulate, any pregnant patient with a risk factor should have the risk factors, high risk factors should be identified. They should have a prenatal screening by ultrasound in the second trimester, 18 to 24 weeks. MRI is required only if ultrasound is not diagnostic. Biomarkers are not routinely used. Once the prenatal diagnosis is done, they should be referred to a multidisciplinary team. Steroid has to be given. Anemia should be corrected so that the hemoglobin levels are optimized, and a good 34 to 36 weeks cesarean section should be planned. If initially a conservative management may be offered if the fertility requirement is there, but at any stage, if the life of the mother is a problem, or we think we cannot save the mother, then immediately hysterectomy should be taken forward without any thought, with good ICU post-operative management and monitoring. So please remember, our expertise and aptness and good clinical judgment can save the mother, the baby, as well as the surgeons, all the obstetricians. Thank you.
Thank you very much for such a nice deliberation. Good evening, and thank you, MC Patel sir, for including me in this series as chairperson. I also want to thank Dr. Asha Jain, Sumandi, Dr. Rekha Rajendra Kumar, ma'am. And the topic was taken by Dr. Meeta Gupta very nicely. She touched each and every aspect of this topic. Nowadays, this is a very common occurrence, especially in tertiary care hospital, like ours, that is RIMS, and it is due to increasing trend of cesarean section. So interesting points in this presentation was, it was started with practical scenario, which we are facing day to day in our practice. The elaborate discussion was about etiopathogenesis, type, grade, risk factors, prediction of risk and complications, detailed tips for diagnosis, even if she is undiagnosed in intraoperative period, we should be highly suspicious, and follow many points are there by which we can pick up the cases of placenta previa, and timely decision and intervention can be done accordingly. So she nicely pointed out that level 2 scan is very important. And if patient has previous 1 CS, previous 2 CS with anterior low-lying placenta, we should definitely refer to radiologist with color Doppler study and meticulous study to localize the placenta. Either it is PAS or it is just anterior one. And so role of USG, she nicely discussed, and we cannot omit the use of USG because MRI having a limited role because it is not widely available, and ultrasound gives rise to many things which can be seen by obstetrician also. So role of biomarker are very limited as per literature, and the management about the, she nicely pointed out that it should be managed at a facility with blood transfusion facilities and with multidisciplinary team care unit. Treatment should, timely treatment and decision can improve the outcome. The time of delivery should be early if any complication is there. And if not, we can carry up to 36 weeks, but we should avoid to start the labor because that may lead to torrential hemorrhage sometimes and partial separation of placenta. Intraoperative period, what preparation should be done, and the team of intensive care monitoring should be there. Blood transfusion, mobilization of massive blood transfusion protocol should be there. What decision should take, primary, cesarean hysterectomy, how to take, and leaving the placenta inside, what is the risk, what is the benefit, and how the emergency obstetric hysterectomy differs from the normal hysterectomy, delayed hysterectomy, what it is, and preoperative precaution like decreasing the vascularity of uterus by endovascular occlusion, the risk and benefits, the stenting, the uterotonics, how, why to avoid, and tranexamic role of tranexamic to decrease bleeding. Uterine artery embolization is again a new dimension of treatment in such cases, and triple TP procedure is very important. So this talk was also about the post-operative management and importance of intensive care unit, and the what are the deadly Ds which should be avoided. So it was a very, very informative discussion, especially for PG students, all the faculties, all the practitioners, senior and junior. So a big applause for such a nice presentation, Dr. Meeta.
Very nice.
Dr. Kiran, congratulations, Dr. Meeta. It was a wonderful and wonderful presentation, simple words. And thank you once again.
Thank you. I thank all the chairpersons for being here. Thank you, Dr. Meeta, for that presentation. And special thanks to Banita ma'am, who has been sick all day and she has still made the effort to join in. So hope you get well soon, Banita ma'am. And with this, sir, may we start the panel discussion now?
You all.
Hello.
Yes, yes.
So, पटेल सर दिख रहे हैं क्या? Patel sir, please unmute yourself.
Yes.
Yes.
So we start the panel now.
Oh, yes.
So welcome, respected panelists, to this much awaited reverse panel. And the topic today is documentation. I will be moderating and sir is the expert to answer all your questions. So in the beginning, I would like to introduce sir. I know he's part of your family and doesn't need an introduction, but it's my duty to introduce him even if it's in short. So sir is a consultant obstetrician gynecologist and medical legal counselor, vice president FOGSI 2018, organizing secretary AICOG 2017, Chairperson, Ethics and Medical Legal Committee, FOXI, 2011 to 13. Other than that, he has had multiple positions in multiple organizations of India and Gujarat. More than anything else, we all know him as our go-to person in case of any medical legal problem, or even if we are afraid that we might land up in a problem, sir is always there to help us. So welcome, sir. I have been introduced, I will be moderating, and these are our respected panelists. So I will be introducing the panelists as they come along in the discussion. In the beginning, I will be displaying a video by sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving FOXI for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of FOXI President year 2026, election year 2024. Consistently working for FOXI and trying to visit even a smaller societies and to assist our common FOXian friends in any given situation, I have tried to serve FOXi. I assure to serve FOXi in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So I would be starting the discussion. As an introduction, sir, I would like to ask you, is it worth discussing about documentation?
Always yes, because whatever we have done for any of our given patient, and whenever we are facing any kind of litigation, then we can prove in court of law by documentation only. So it is a very important part in our day-to-day practice, and records are always at our rescue as far as medical legal problems are concerned.
Sir, is there any case that is decided against a doctor and only on the basis of documentation or records?
Yes, there are so many cases, but I would like to mention a few. In one of the cases which happened in city of Ahmedabad only, it was a case with ENT surgeon, and patient was for tonsillectomy operation. Patient was a nephew of his own compounder. So it was totally to go for free of cost. There was no charge to be collected. So doctor took it very casually and he didn't prepare any record. He didn't take even consent. And unlucky on part of that patient as well as the doctor, during surgery on table due to some anesthesia complication, patient expired and case was filed. There was no documentation. There was no record related to that very patient, no consent, nothing. And case was decided against doctor. In one more case, it happened again in state of Gujarat only. In one small town of Pratij, patient had been to that gynecologist at 7 a.m. early morning with labor pain, and on examination, it was breach at perineum. And doctor had no way to deliver the patient. This was very first visit with that very doctor. And previously, patient was taken care by some other gynecologist at an in-laws place, but it was first delivery. and customary tradition, usually in Gujarat, first delivery maternal place. So she had been to her mother's place and patient was brought to the doctor. Deliver that patient by assisted breech delivery. But after normal delivery of placenta and membrane, she developed sudden convulsion and cardiac arrest.
तुम्हारा हम देखते हैं क्या कर सकते लेकिन
I request everyone who's not speaking, please mute yourselves. Please mute yourselves.
So in this situation, patient was resuscitated well, help from anesthesiologist, physician were taken, and patient was shifted to tertiary care center for further care. But during course of treatment, on 4th day, patient expired. Case was filed. Doctor had prepared all the case, I mean documentation, records, about treatment given to that patient, and he handed over all the case paper to the advocate. But doctor didn't bother to remain present.
प्लेटलेट कम हो जाता है जिसके चलते इतना ब्लीडिंग होता है प्लेटलेट में कम
Shashi Bala ma'am, please mute yourself.
Excuse me, Corona, Vasu, Nilesh, please mute everyone. Please. Whoever is not speaking, please mute.
So, doctor handed over all the case papers or records to the advocate, but he didn't bother to remain present in the court even once. And for any reason, advocate didn't produce those records in court of law. So case was decided against doctor in spite of all the care and caution took by the patient in a very nice way in that very given situation. And compensation of 2.35 lakhs was awarded in favor of relative of the patient. So these are the two examples in which one record were not at all prepared, and second, though it was prepared, it was handed over to the advocate, but for any reason, those records were not produced in court of law. So documentation or records are always at our rescue whenever we are facing any litigation. So it is very important part.
Thank you, sir. So now I would like to call upon Dr. Amita Gupta ma'am, who's the past president of Jammu Obstetric Gynec Society. Her hobbies are dancing and singing, and she didn't send me a photo. So welcome, Amita ma'am.
Good evening, everyone. Sir, my question is that, is it important to document everything? One. Second, I would like to know that how long we are supposed to keep the records of indoor and outdoor. And I have just recently gone through some a statement that we are supposed to keep the record of this cesarean or vaginal delivery for the baby for 20 years. So I please confirm.
Amita ma'am, the second question is later, please. Only the first question right now.
So what is the purpose of documentation?
So naturally, just I mentioned prior also, whenever we are facing any litigation, records are always at rescue. And from record, it shows that quality of care taken by us. So how we have managed the patient, how effectively, efficiently, meticulously we have managed the patient. It is only be approved by documentation or record. It shows coordination of care, how step by step we took care of that very patient. And it shows that how we have taken care as far as patient safety is concerned. And it provides us legal protection also. And as far as research and continuous education programs are concerned, documentation are very important or instrumental rather in our research project also. So documentation is very much important.
Thank you, sir.
Yes, welcome, madam.
Thank you, sir. So the next question is from Dr. Shehnaz Tang. She is the president of Srinagar Society. Sir, have a look at her garden.
Yes.
I have made 2 slides and just see her avid gardening. Means everyone can just have a look. Great. Over to you, ma'am.
सहनाज मैडम विजिट करना होगा आपका गार्डन.
Heavenly look, sir. Agreed, sir.
Shahnaz, ma'am.
Is she there?
Ma'am,
She
please
was
unmute
here, sir.
yourself. Shahnaz ma'am is there, but ma'am, you need to unmute yourself. Please unmute yourself, ma'am. Shahnaz ma'am, please unmute yourself. You're still, yeah.
Am I audible now? Am I audible?
Yes, madam.
Yes, ma'am.
Yes.
My question is, which are types of documents, oblique records?
So
Which type of, what are the types?
Yes, there are three types of record we have to preserve. One is clinical record, second is administrative records, and third is financial record related to that very patient's payment, etc. So we have to go like this. And as far as clinical records are concerned, say for example, OPD register. We start with OPD register, and under Income Tax Act, we have to maintain OPD register in a very prescribed form, that is Form 3C. In that very form, or in OPD register rather, name and address of patient, professional services rendered, say for example, consultation, reconsultation, or indoor, or IUCD, whichever services we have offered, and fees collected or fees received, and receipt number of fees collected. So these are some columns prescribed under Income Tax Act, and we have to maintain OPD register that way. Same way, indoor register, naturally in indoor register also name and address of the patient, date and time of admission, date and time of discharge. If patient is operated, then date and time of operation, diagnosis, nature of treatment or nature of professional services rendered, fees collected, and receipt number. So we have to maintain indoor case paper that way. OPD case paper and indoor case paper. We have to maintain all those OPD case paper and indoor case paper also. Any other records related to that very patient or treatment given, if we are having ECG report or sonography report, but usually we have habit to give all those report to the patient. So we have to mention that report of sonography is given to the patient, report of ECG is given to the patient. But if we have copy of that record, then report, then we have to preserve those report also. And all this clinical report should be fully written with all the details, because whatever treatment we have done, whatever management we have offered to the patient in that very situation, we can prove only by record. One more important part is certificate. If at all we have issued any kind of certificate to the patient or patient party, then copy of that very certificate should be with us. And opinion or note from other doctors. If we have involved our professional colleague in treatment, then note from there our professional colleague should also be there, and it is to be attached with patient's case paper. So seen by Dr. So-and-so, his or her findings, any investigation if she has advised, and a treatment, whatever treatment he or she has suggested. So we have to maintain that also. Some other register also, as far as part of clinical records are concerned, autoclave register. Say for example, whenever we go for any surgery, and if something goes wrong, and there could be allegation on part of prosecution, in case of sepsis many a time, that proper sterilization was not done, or proper sterilization of linen, etc. was not there. So this could be one allegation, and we can prove it by autoclave register only. So we have to maintain that register when sterilization part was started, and autoclave rather, and when it was over, and that a sticker, that is Signalock, which is green in color, and after autoclaving, it turns into black, and that Signalock is to be pasted in our autoclave register. It shows that we had autoclave in a very efficient manner. Some more register like ultraviolet sterilization of OT, labor room, ICU, we have to maintain that also. IUCD register, female sterilization register, birth, death and stillbirth registration, register, a blood and blood product transfusion register. So these are some other document as far as clinical records are concerned. One more part is consent. Whenever we have taken consent of patient or patient party, it is also important part of our document as far as clinical record is concerned. So these are some clinical records we have to maintain.
Thank you. Thank you.
Thank you, sir.
Yes, welcome.
Thank you, Shehnaz ma'am. And this is Dr. Nigat Firdos from Srinagar again. She loves traveling. So these are photos of Kashmir and this is Turkey. So over to you, Nigat ma'am.
Thank you. Can you hear me?
Yes, ma'am.
Good evening, Mr. Patel.
Yes, madam.
Yeah, I want to ask you about the abbreviations we use. I know that there are some advantages of abbreviations being used. We know it's less time consuming. It is, exactly, our staff is well versed with it. So it is a way of communication. Then, but we need to know that the patients don't know the abbreviation. So what would be your advisory, medico-legal advisory?
So as far as abbreviations are concerned, of course, we are well versed with abbreviation. We all have habits, say for example, NAD, nothing detected. It is very usual. Say for example, PID. But as far as litigations part is concerned, court never entertain. Court are never happy with this type of abbreviation. Because say for example, PID, in our gynec fraternity, we considered as a pelvic inflammatory disease. But in orthopedic, they considered as a prolapse intravertebral disc. So in this, say for example, IUD, intrauterine death, and some may call it intrauterine device also. So there are so many confusion as far as abbreviation part is concerned, and court are not happy. Many times, simply it is written like SCOPV. So we all are surprised. What is SCOPV? So it is meant as far as this doctor has used this abbreviation, something coming out of or per vagina. So this type of abbreviation, of course, we use in our day-to-day practice, but court is not happy with this type of abbreviation. So it is always better to write in full. And particularly whenever we are facing any litigation and whenever we submit any record to anybody, at least before that, all those abbreviations should be written in full. This is advice.
Thank you. Thank you.
Yes, next.
Dr. Shashibala ma'am.
Dr. Shashibala Singh ma'am. I couldn't contact her today also, sir. She didn't pick my phone, but she was here.
No, she was there. She was there.
She was there.
Actually, ma'am, she is there, but she is having some problem in audio connection. She just now talked to me.
Would you mind asking the question, Dr. Archana? Aap pooch lo.
Yeah, sure.
Hello.
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 Yes,
Am I
ma'am.
audible?
हाँ हाँ
Yes,
Shashi
ma'am.
आप बोलिए.
Myself, Dr. Sashibala, may I audible?
Yes, yes, madam.
Good evening, sir.
Good evening. Good evening.
There is some network issue with me. My question is, which are the provision about the leave certificate?
Leave certificate?
Yeah.
Yes. So before I answer, it was my privilege to be associated in your installation ceremony when you took
Thank you
over
so much,
office
sir.
as a President Ranchi and Archana Kumari as a secretary.
Thank you,
So,
sir.
yes,
Thank
welcome.
you, sir.
So, as far as the leave certificate is concerned, many a times patient or relative of patient ask for certificate to grant leave if they are working women
Yeah.
or so. So, we can give and we have to give certificate. But as per a standard guideline from MCI and now newer version of NMC, there are some guideline as far as leave certificate is concerned. We have to mention full name of patient, age, address, diagnosis if possible, that a patient was being treated for this very disease or so, and rest for how much days we have advised rest for the same, and identification mark of the patient should also be mentioned. And to be on safer side, we should take right hand thumb impression of patient, because in one of the cases which happened in state of Gujarat only, patient was produced as a name, say for example Mrs. X, but as such he was not Mrs. X, and certificate was issued with name of Mrs. X. So in this type of situation, many a times we may be put into trouble. So if we have taken identification mark or thumb impression, we can say that we had issued certificate to the person whose thumb impression is with us and whose identification mark are with us. Whether she is Mrs. X or Mrs. Y, that is up to prosecution to prove. So in this type of situation, we should be very careful as far as any leave certificate if we grant. Many a time, relative of patient may ask for some certificate, because in few of the condition it has happened. Say for example, husband of patient was in custody for any reason, and he had applied for bail on ground of his wife health issue. So many a time patient comes to us to give certificate that I was suffering for this ailment and I was under your treatment, and one person is needed to take care of me for certain period. So this type of certificates are also being asked from patient party. Of course, we can give in this type of situation, but we have to inquire everything in detail and strict to whichever condition, whichever disease, whichever ailment we have treated, and for that very ailment, how much leave we can grant should be very specifically mentioned. Because if at all this type of certificates are challenged in court of law, then we should be in a position to justify our certificate which we have issued.
Okay, sir. Thank you, sir.
Thank you. Welcome.
Sir, there are different types of the leave certificates. Sometimes patient take the leave, and after some time they came and they told us कि आप हमें बता दीजिए कि हमने इतने दिन का छुट्टी लिया था, आप इस बैक डेट में बना दीजिए. तो
never entertain patient to issue certificate in back date. Again, I would like to quote one incident which happened in state of Gujarat only. Medical officer in that very center issued a certificate to a person that he was under my treatment for 3 days from this date to that date. As such, that very person was in custody for that very 3 days. And he was working in GEB, that is Gujarat Electricity Board. And Gujarat Electricity Board had some suspicion. So they inquired with that very police station where he was in custody, that please give us the detail about Mr. So-and-so. Was he in your custody for this period? So when he was in custody, police station issued the certificate that he was in our custody. And GB filed a case against that fellow also and to that doctor also for fabrication of evidence, and it becomes a crime under Indian Penal Code. So in this type of situation, it becomes very difficult for us to save ourselves in a court of law.
Yes.
So it is always better not to issue any leave certificate in post-dated. Patient should be before us only, and we
Yeah.
student can issue certificate on that very date only.
Thank you so much, sir. Very well explained. Thank you so much.
Yes, next.
So next we have Archana Kumari ma'am. She is the secretary of Ranchi Society. Archana ma'am, over to you. She is an ardent teacher and just teaches and teaches and teaches. So Archana ma'am, over to you.
Thank you, ma'am. Sir, my question to you would be, what is the importance of discharge card as a document?
Very important document because it is a face of our treatment given.
Yes.
So we have to mention everything in detail in discharge card: name of patient, age of patient, address of patient, probable, a provisional or final diagnosis. If we have not come to diagnosis, that we can mention into bracket under investigation, but we have to mention that, and all the investigation, treatment, and very important part is instruction to be given to the patient at the time of discharge. Say, for example, diet to be taken, medicine to be taken, exercise, follow-up treatment, or any reference. If we have advised any references to any other professional colleague, then we have to mention everything in detail in discharge card. Because in one of the case, there are two decided cases in very recent future. One happened in state of Gujarat only. So in first case, it was happened in state of Tamil Nadu. It was premature delivery, and baby was admitted in NICU. In due course, baby was discharged from NICU. But as it was premature delivery, parents of baby were never advised to go for opinion from ophthalmologist in discharge card. And in due course, baby went blind due to retinopathy due to prematurity. Case was filed, and 1.8 crore of compensation was awarded in favor of patient and relative of patient by Supreme Court. And out of those, 1.73 crore was to be paid by state of Tamil Nadu because it happened in government hospital, and rest of the amount was to be paid by a neonatologist. Of course, gynecologists were lucky; they were not made part in that very case. But this is very carry home message in this type of cases, that at the time of discharge or during course of this type of cases, we should refer patient to a proper person. So it was happened. Again, same type of case happened in state of Gujarat only. So in Gujarat, preterm delivery again, and baby was admitted for 42 long days. But during those course of 42 days, patient party were never advised to go for opinion from ophthalmologist.
Ophthalmologist, yes.
Discharge, and after discharge, baby has a complaint of watering from the eye. Baby was taken to a gynecologist who delivered that baby, and again gynecologist didn't refer patient to ophthalmologist, and she prescribed some eye drops. Again, and this was her maternal place. And then patient had been to her in-laws place. Patient had been to Mumbai and in Sankar Netralaya in South India, and diagnosis came to be retinopathy due to prematurity, and ultimately baby went blind. Case was filed, and very recently judgment came, and 86 lakhs of compensation is awarded in favor of patient and patient party. And in this very case, as far as this documentation part is concerned, I have mentioned this particular case. So when patient party asked from the hospital about documentation of treatment given, they didn't produce documentation or record to the patient. And it was also one more allegation on part of patient party. So compensation of 75,000 more, 86 lakhs was awarded, and 75,000 more for record was not submitted to the patient party when they had demanded from the hospital. So it is very important whenever patient or patient party asks for any document or records of treatment given, we are under obligation to issue.
Yeah, thank you, sir. Sir, one more question related to this only. Sometimes I have seen that suppose during cesarean section, if or previous cesarean, some bladder injury, small rent occurred, was repaired, and patient was discharged uneventfully. But I have seen many obstetricians are not mentioning it in the discharge ticket.
Yes.
So, what should be done? Like,
so post-operative counseling is equally important in this type of situation. Whenever we met any complication, we have dealt with accordingly. Say, for example, just you mentioned about bladder injury. So we have to mention, because naturally when we discharge this type of patient, we will discharge patient with catheter only, because we will not keep patient for long 2-3 weeks merely for catheter in situ. So when we discharge this type of patient, we have to mention everything in case this discharge card about this complication which we dealt with, and all the instruction related to that complication part after discharge. So it is very important. And if you have not mentioned, so it will be again we are hiding something, and it could be one more allegation on part of patient or patient party at the time of litigation. So it is always better to mention everything in detail in discharge card.
yeah, I agree. Thank you, sir.
Thank you, sir.
Yes.
So now the next question is from Dr. Nivedita. We all know her. She loves interacting with people and she loves dancing. So over to you, Dr. Nivedita.
Yeah, I
So
love talking.
Okay, I didn't know you
Vinod
are a
has to go
doctor.
somewhere. So can we take
Yeah.
his questions earlier?
Right. Yeah, sure. Whose question you
No,
want earlier?
Dr. Binod, I'm asking sir. Sir, Dr. Binod wants his questions to be taken earlier. Is
Oh,
that
yes,
okay?
no, we can.
Okay.
Okay.
So Nivedita, after you, I will ask him to ask his
Great.
question.
Great.
Yes, welcome,
Uh,
Vinod.
Good evening.
Good evening.
Nice to see you again in a very short
Yes.
while.
Thank you.
We
Hi,
met
Dr. Vinod.
It
recently.
was
Hi,
my
Dr. Vinod.
privilege to visit
Hi.
Jamshedpur Society.
Sorry, a bit. I'm getting a bit late.
No
So,
issue. Welcome.
sorry,
Yeah.
people.
Yeah, I'll just go through it it's depending on how fast sir answers the question. Good evening, sir. Good evening, sir. And good evening, everyone. We've already discussed about in-house documentation, and just now Archana asked about documentation at the time of discharge. So now, what is the importance of transfer documents if you're transferring to a referral center?
So it is very important thing again. When we transfer any patient to higher center for further care, then we have to give all the reports or all the document, we may call it transfer document also, to the patient party about treatment given at our place, with all the details, all the investigation report, all the treatment given, because it will be very useful to the person whom we have referred the patient to manage patient further. So in this type of situation, so whether, say for example, at the time of admission, we have to mention about vitals, pulse, blood pressure, saturation, temperature, respiratory rate, and at the time of transfer, we have to mention that. So it becomes very important parts as far as these vitals data are concerned for person who is going to manage that patient further. So one more area, whether we have patient referred in ambulance or in any other private vehicle, we have to mention that also in that transfer paper, and whether that ambulance or that private vehicle was managed by hospital or managed by patients or patient party by their own. So there are so many points as far as these transfer documents are concerned, but you are not to worry. You have to simply visit Foxy website, and on Foxy website there is Foxy uniform consents available. We three medical legal expert, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. Say, for example, cesarean, hysterectomy, os tightening, and so on. So we have prepared one consent for this type of patient when we refer patient to higher center for further treatment. And we have mentioned everything in that transfer document, which kind of document we have to hand it over to the patient party. So this is very important part as far as transfer document is concerned.
So does the same hold true if the patient is going against medical advice at DAMA or LAMA?
Yes. Whenever we discharge any patient or we discharge on request, we have to submit all the record to the patient. When patient discharge against medical advice, then also it is always advised to give all the record of treatment given at our part.
Dr. Vinod.
Yes. So, but one thing I would like to mention about Nivedita. Nivedita is very hard-working Foxian, and she is working very hard as far as Safe Motherhood Committee is concerned. She is traveling a lot across India physically, because previously I was thinking like I am traveling so lot in many of the society, but Nivedita is also equally traveling a lot as far as concerned.
बहुत पैसा खर्चा होता है.
And on webinar also, and doing very good work as far as Safe Motherhood Committee is concerned.
Thank you, thank you, thank you. आप लोगों का आशीर्वाद है सर.
Now, Dr. Vinod Agrawal, sir,
Good
President
evening,
Jamshedpur Society. Ji, sir.
Asha ma'am, good evening, and sorry I could not send that photograph on the request. Sir, I had a question.
Yes.
Like so many records, you know, you have to maintain this, you have to maintain this. Can you just elaborate how to destroy these hospital records further?
So there is a specific procedure as far as destroy of record is concerned. Straightway you cannot destroy record. So you will have to give advertisement in two newspaper, one in English and one in vernacular language. And in that very newspaper, you will mention that we are going to destroy record from this date to this date about the patient we were treated in our hospital. So whosoever interested, any eligible person who is interested to get that record are requested to contact hospital during this period from this date to this date. After that date, all the record will be destroyed and hospital or doctor will not be responsible for any record. So this type of advertisement we have to give in newspaper, and then after we can destroy record. But as far as destroy of record is concerned, simply we cannot give all those record to Pastiwala. We have to destroy that record way in which they cannot be reused or misused in future. We may thread it to pieces or we may burn all those records, but whichever way we destroy that record, they should not be in a position to be reused. So these are some guidelines as far as destroy of record is concerned.
So thank you so much, sir. One more question I have.
Yes.
This is regarding this era of technology about the digital records.
Yes.
So everyone is using online platform or
Yes.
some their own
Yes.
softwares.
So
how valid are they?
Yes, they are very much valid. We can have a record on paper, on dictaphone, on computer, or any other electronic media. But in few of the laws, say for example, PCPNDT Act. In PCPNDT Act, there is a provision. If we preserve record on electronic media, then we have to take one copy of that record and it is to be authenticated by person responsible for that maintenance of record. Otherwise, we can preserve record in electronic media also. It is very much valid in court of law.
And there is now there's a trend, you know, when you're counseling the patient, we do a recording, audio recording, a counseling, a clinical. Does it help?
Yes.
And can it serve as a evidence in the court of law?
Yes. As far as video recording is concerned, I usually say like this, it is a double-edged sword. Because many a time when we are counseling and video recording is going on, if we miss very important point for discussion, so smart advocate on part of prosecution will catch us in the court of law that this important point you didn't discuss with my patient, my client, and that is why patient was in a dilemma and patient gave a consent with some confusion. So whenever we are going to go for video recording of any counseling or any consent, we should be ready with all the document which we are going to discuss in written on our table. So no important point should be missed as far as communication or counseling part is concerned at the time of video recording.
Thank you so much. Thank you so much, sir. Thanks. Thank you so much.
Yes, welcome.
Thank you, Binod sir. Thank you, MC sir. Sir, I didn't tell you, but sir loves singing and he also loves running. So
And
that
Dr.
accounts for his fitness.
Dr. Vinod is also good host, because I had a privilege to visit Jamshedpur Society very recently and he took utmost care of mine as far as hospitality is concerned. Thank you, Vinod.
Thank you so much. Thank you. I'll
So,
take your
sir,
leave. Sir.
thank you, sir. Thank you, sir. So, sir, now we have Arpita ma'am. Arpita Gandhi ma'am. She's the new society. The new society of Devghar. And we know her. I know her since my son was a student.
Yes.
But we didn't know it's she. And she loves cooking and gardening. But more than that, sir, she actually educates the underprivileged. And not just class 1, class 2, but the whole through. Kitna bhi padhenge, if they are poor, she facilitates their learning. So kudos to you, Arpita ma'am, and over to you.
Good evening, sir.
Good evening, welcome.
Good evening, sir.
Good evening.
Am I audible?
Yes, you are audible.
Yeah, good evening, sir. We are eagerly waiting to receive you on 1st December at Devghar Airport.
Yes, I'll be there.
And ours is a sapling society.
Yes.
And through this platform, I invite all the presidents and secretaries of Ranchi, Jamshedpur, Dhanbad, Bokaro who can come by car. Please come and bless us on 7th November. Time is very less. Today only we got our cards. I will send cards also. So please come. Sir, my question is, what is good record? And give some tips about records.
So as far as these records are concerned, we have to maintain all those records in a very meticulous manner. Just we mentioned prior also. Records should be very clear. It should be easily readable one. Because many a time there is one comments or rather complaint rather we can say that records or any prescription given by doctor is not readable. So it should be very clear. It should be in a chronological order. It should be very comprehensive. So whatever we have mentioned about treatment given, we have to mention all this. So it should be clear, it should be correct, it should be comprehensive, it should be chronological, and it should be contemporaneous. Because whenever we maintain record in a very clear way, because many times when we face litigation and when we have treated the patient very years together, we have to face this type of litigation in court of law. And many a time, if it is not clearly readable, then it will be difficult for us also to read and to interpret and to say something in court of law. So it should be very clear, correct and comprehensive. Yes, next.
Asha ma'am.
So, sorry. So now we have Dr. Priyanka, sir. So she loves cooking and gardening. reading and writing. That's her hobby. She is again secretary of Deghar Society. Over to you, Dr. Priyanka. Are you there, Dr. Priyanka?
I haven't seen Priyanka in the participants list.
So then Archana madam can
Okay.
take.
Yeah, I can take.
Yes.
Take it, ma'am, please.
Okay. So, sir, my question to you on behalf of Dr. Priyanka Roy is, if the patient is not complying, should we enter it into record?
Always yes. Because whenever patient doesn't comply, it becomes a contributory negligence on part of patient. So everything we have to mention in our case paper. Many times you will be observing that person who is accompanying the patient will complain, doctor, she is not taking medicine properly, she is not taking proper diet, she is not taking milk. So make a habit to enter into the record. Patient is not taking treatment properly, history given by mother-in-law or whosoever is accompanying the patient. Because it becomes a good evidence, it becomes a good defense rather in your favor whenever we are facing litigation in this type of situation. Because it becomes contributory negligence on part of patient.
So sometimes it happens in our institute, it is very common. Patient of severe anemia comes to us. Of course, under JSSK for obstetric patient, we are providing free blood, but not for gynae patient. And they are not able to donate. They are not willing to donate. So shall we write? Patient is not bringing blood like every day documentation.
We have to advise. We say for example, we have advised blood transfusion. Or
But if they are not complying it,
yes, I am coming to it. Or blood product transfusion, we have to advise. If patient or patient party do not manage to arrange for blood or blood product, that is not up to us. Of course, we can guide them, we can help them, but primarily they are person concerned to manage. So if they do not, then if we have mentioned in our case paper that we advise or we send sample of blood for grouping and cross matching, etc., and they didn't turn up with blood or blood product which we had advised, we are saved in court of law. Because in court of law, ultimate results are not taken into consideration, but your efforts to save life of patient are always taken into consideration.
Thank you, sir.
Yes.
सर कहीं पे डॉक्टर अनुप्रिया पंकज का नाम मिस हो गया है.
Anupriya is secretary of Bokaro Society.
Yes, पर इनके क्वेश्चन छूट गए सर. ये मुझे जो दिखाना था
नहीं उनका क्वेश्चन है अब ये
हाँ मैं दिखा रही हूँ सर. ये देखिए, ये इनका आर्टवर्क देखिए.
Yes, very
just
good.
see her artwork. Means everybody can really have a look. It's so beautiful.
I know.
And now over to you, Dr. Anupriya, Secretary, Bokaro Society.
Good evening, sir. I'm Dr. Anupriya from Bokaro. Sir, my question is, what is administrative recording?
So, as far as administrative records are concerned, certain law we have to observe during our practice, and all the records related to that those acts rather, they are administrative records. Say for example, PCPNDT. If we are doing sonography services, then we have to maintain PNDT register under Rule 9, Sub-Rule 1 with 4 columns: serial number, name and address of patient, name of husband or spouse, and date on which patient consulted for that very record. So this type of PNDT register we have to maintain under PCPNDT Act. One more, all the forms related to PCPNDT Act. Say for example, if your center is registered as a genetic counseling center, then Form D. If your center is genetic laboratory, then Form E. If your center is registered as a genetic clinic or sonography center, then Form F. And if you have gone with any invasive procedure, then Form G. We have to take consent of patient in Form G. So all these forms we have to observe as far as the PCPNDT part is concerned. And one more part, as a part of record, we have to display board in our waiting area or be at that place of business at conspicuous place with name of our clinic, address of clinic, and writing like this: sex determination is punishable offense or punishable crime, and this type of determination is not done here. So this type of board we have to display at the place of business at conspicuous place. One more administrative record part is copy of PCPNDT Act. So bare Act, that is copy of bare Act of PCPNDT Act, should always be available in our clinic if our center is registered under PCPNDT Act for perusal of any visitor. So we have to keep ready the copy of bare Act as far as this PCPNDT part is concerned. If our center is registered as a MTP center, then we have to maintain some records related to MTP Act. So, say for example, Form A, at the time of registration, we apply in Form A. So one copy of Form A should be with us. If we are registered center under under MTP Act, then we are issued with a certificate of registration, that is Form B. Then that Form B we have to display at the conspicuous place at the place of business. So in waiting room also we have to replace. One more form is Form C, and Form C is consent form at the time of MTP. So we have to preserve that Form C also. One more form is Form D. So when pregnancy is more than 24 weeks, and we have asked for opinion from medical board, and if medical board has opined, medical board will opine in Form D. So copy of that Form D, if we have terminated pregnancy more than 24 weeks on opinion of medical board, we have to preserve that Form D. Some other forms related to MTP Acts are Form 1. Form 1 is a form of opinion. So up to 20 weeks of pregnancy, one registered medical practitioner will form opinion in Form 1. So Form 1 we have to preserve. Form 2 is also one more form as far as MTP Act is concerned, and it is monthly reporting form. So at the time of reporting at the end of month, we have to report appropriate authority in prescribed form, that is Form 2, and copy of that Form 2 is also with us. Form 3, we can call it admission register or MTP register. In that Form 3, all the details of patient who is undergoing MTP is given there. Name of patient, address, how much delivery patient had previously, and which method of contraception he is going to adapt after MTP, opinion given by whom, termination of pregnancy done by whom. So all the columns are there in Form 3, and we have to maintain that record of Form 3. One more form is Form E. So if pregnancy is more than 20 weeks and less than 24 weeks, and if we have terminated pregnancy, we can terminate that very pregnancy with opinion of 2 registered medical practitioners, and we have to form opinion in prescribed form, that is Form E. So we have to maintain all those record or forms rather related to MTP Act. So these are some administrative records we have to maintain.
Sir, where can we get all these forms?
These are available on net also. You have to simply mention MTP Act and you will get all those forms. As far as ART part is concerned or surrogacy part is concerned, if you are practicing ART, then you have to maintain all the certificates and all the records related to ART and surrogacy also. These are all administrative records.
Thank you, sir.
Yes.
Thank you, sir.
Yes.
Thank you, Dr. Anupriya. Now we have Dr. Gayatri Singh, sir. As you can see, she loves religious traveling and she does a lot of camps and everything. So she is the president of Dhanbad Obstetric Gynec Society.
Yes.
And she also loves gardening. Dekhiye.
Very good. Very good.
Beautiful garden.
I
So
will have
over to you, Dr. Gayatri.
I will have to visit Gayatri Madam's garden at my visit at Dhanbad. Yes, Gayatri Madam, welcome.
नहीं दिख रही हैं.
हाँ, वो है मगर उनका म्यूटेड है. गायत्री मैम
Muted.
है.
Yes, please unmute, madam.
एक बार मैं कॉल कर दे. अनम्यूट
Am I audible? Am I audible?
Yes, ma'am.
Yes, ma'am. Welcome.
Good evening.
Yes, ma'am.
Good evening. Good evening.
Ma'am, I would like, I am very humbled to get this opportunity by you people to panel this medical legal discussion, which is a very important part in our medical practice and it is getting importance day by day. So I would like to, my question of today is, I would like to know what are financial records first, and second is what is the importance of prescription bill. Sir, over to sir.
So as far as financial records are concerned, all the financial transaction with patient, we have to maintain all those records. That is bill book or invoice, receipt book, cash book, bank book, ledger, voucher book, salary register of our staff, and staff attendance register. So these are all some records related to financial part of the hospital is concerned. So we have to mention. You ask one more question about importance of purchase of bill. It is very much important, or not only purchase of some instrument or some medicine, say for example, emergency medicine, purchase of oxygen cylinder, purchase of some emergency instrument like ambu bag or so. It is very important. But many a time on part of prosecution, there could be allegation that when patient suffered this complaint, you had this facility. So with this bill of purchase, we can show that we are equipped with all these instruments. But as far as oxygen cylinder is concerned, not only bill of purchasing oxygen cylinder, but refilling of oxygen cylinder bill is also equally important. Because in one of the cases which happened in state of Gujarat only, allegation on part of patient party was when patient suffered heart attack, oxygen cylinder were empty. And we were saved in court of law with the bill which we could produce in court of law. We had bill of refilling of oxygen cylinder 1 day prior of this accident happened. So with that very important bill of refilling of oxygen cylinder, we were saved in court of law. So purchase and refilling of oxygen cylinder and all purchase of our emergency drug and other instruments are very important document in our hospital.
Thank you, sir. Thank you, sir, for this nice information, sir.
Yes.
Thank you, sir.
Thank you, sir.
Sir, financial regarding financial records, sir, for how long it should be kept? It should be kept with us, sir.
I think the
financial.
Asha madam, I think this question is to be taken.
Yes, sir.
Any separately?
Later. It will come later.
So it will include, madam. Gayatri,
Okay,
madam.
thank you, sir. Thank you, sir.
So,
Thank you.
We have this beautiful secretary of Dhanbad Society, Dr. Neha Pridarshi. So your name is Pridarshini and you're also Pridarshini. Beautiful.
Thank you
Loves
so
dancing and singing. So over to you, ma'am.
Thank you so much, ma'am, for the compliment. Good evening, everyone. And my pranam to Patel sir and all the seniors present here. So my question to you, sir, is how records can be maintained and for how much period we should preserve the records?
So how we can maintain record, just I mentioned prior also, we can preserve record on paper, on dictaphone, on computer or any electronic media, we can preserve our record. And as far as the period of preservation is concerned, so if we go by law, then as far as MTP Act is concerned, all the record related to MTP, we have to preserve for 5 years. As far as PCPNDT part is concerned, for 2 years. as far as ART part is concerned, for 10 years, and after 10 years, we have to transfer all those records to National Registry. As far as surrogacy part is concerned, for 25 years. So these are the provisions as per law. If we go by guideline on part of MCI or on part of NMC, newer version of MCI, then we have to preserve all the record related to OPD at least for 3 years, indoor case paper for 7 years. And as far as obstetric records, that is delivery records are concerned, question was asked prior also by some faculty, for 21 years. Why? Because after attaining majority, after 18 years, that child within 2 years of period can complain that when I was in womb of my mother, doctor didn't take proper care. That is why I am suffering this. So this type of course, cases are not found frequently in India, but in foreign country, this type of situation our doctor friends are facing. So we should be careful. And as far as obstetric part is concerned, delivery part, records are concerned, we should preserve all those records up to 21 years of period. As far as income tax part is concerned, at least for 7 to 10 years.
Thank you so much, sir.
Thank you, sir. I would like to actually add to that. You need to find out your state rules as well.
Yes.
In our state, in indoor tickets, I just asked permission. So they said, keep for 5 years, then publish in 2 papers that you are destroying records older than 5 years. And if anybody wants anything, they can ask for it. And then after 7 days, you can destroy the records. That is the rule here.
Yes, I mentioned prior also, if we give in 2 newspaper, one English and one vernacular, and we mentioned that from this period to that period, we are going to destroy record. Any eligible person can collect record from hospital. And after that date, when we are going to destroy our record, hospital will not be responsible. So that way, but you are also right. So if any guideline on part of state, then we have to comply with the guideline of state also.
Thank you, sir. So yes. Dr. Binod has already asked his question. Ma'am has also asked a question. So now, Arpita ma'am, one more question for you. Arpita ma'am?
Yeah. Am I audible?
Yes,
am I audible?
Yes, ma'am.
My one question is that you all are knowing that we lost a very competent gynecologist at Jhumri Tilaiya. Her name was Preeti Rani Tara. She expired 3 hours after her cesarean section.
No, after 6 hours.
Dr. Alankrita's clinic. And her husband has filed a case against Dr. Alankrita, claiming that her nursing home was not having an ICU. So is it necessary, sir, that each and every clinic or small nursing homes, ICU should be there to operate a case of cesarean?
No. So in one of the cases, there was some guideline on part of court also. So many times, so many people, even advocates also interpreting that ICU should be there whenever you are going to go for cesarean section. But it is not mandatory. If it is there, it's fine. Otherwise, without ICU also, we can conduct cesarean section.
Thank you, sir.
Thank you, sir.
So, Apoor, the newly elected chairperson of Sexual Medicine Committee, loves traveling, and here are his photographs. So, over to you, Apoor. Welcome.
Thank you so much, ma'am. First of all, I would like to thanks to MC Patel, sir. I have been part of Happy Learning, I think from last 1.5 years. And it's really been great to have a Happy Learning session with all the stalwarts. And all the presidents and secretaries of my own state, Jharkhand is there. I am naman to all. And Usha Nath ma'am, Pranam ma'am, thank you so much. Sir, what about the birth certificates? Because many times the patients are coming and nowadays previously it was like kahin par bhi birth hota hai, they are asking ki bhai aap ek certificate bana do. So what is the importance and what is the documents required for the birth certificates, and which are the provision if the patient and relative want to edit the information of birth certificates? And next question is, sir, if birth is not registered in time, then what is the provision in the law to get the birth certificate?
Yes. So as far as birth, death and stillbirth are concerned, hospital is under obligation to register to appropriate authority, and there are prescribed form for the same. As far as birth registration is concerned, that is form 1, for death form 2, and for stillbirth form 3. It is prescribed form on part of government. So there are two provisions. You may submit physically also, and in few of the states now it has become mandatory rather to submit online. So you can submit online also, whichever the way in your respective state it is prevailing. So within 21 days,
21 days,
you are under obligation to register birth to appropriate authority. If you miss to register within 21 days, then you can register birth after 20 days or also with some late fees. But there is for 1 week or so. After that, all the records from that authority will be shifted to higher authority. And in this situation, if at all you have to go for registration of birth, then you will have to go to the court, you will have to get affidavit, and it will be affidavit on part of patient, patient party, the father or mother of patient. Of course, you will assist them, and then only you can have registration of birth if you have missed to register birth after 1 month or so. So what was one more question?
Sir, if they want to change the details.
Yes. So many a time it is also on, we have observed that it is request on part of patient party to edit name or edit
year of birth.
We can very well entertain them, but when we have submitted record to appropriate authority, straightway we cannot do. We can issue no objection certificate that this change is made by office of registration. Hospital or doctor has no objection, and with this no objection certificate, patient party will approach appropriate authority and they will submit all that record back to the hospital, and hospital will edit the record and again resubmit that record to the appropriate authority. But it can only be possible up to 21 days with that very appropriate authority. After 21 days, if at all any addition is required, then one will have to approach to court with a petition in court as far as addition of record is concerned.
Thank you so much, sir.
If birth is not
registered.
Pardon?
The third question is also there.
You haven't taken the third part. If birth is not registered in time, Apurv.
No, sir took it. Sir took it. Sir took that question.
Sir already answered. I think sir already answered.
Yes.
So, sir, this is more of the garden from Dr. Shehnaz.
Very good. Again,
Kashmir.
you have to visit Srinagar.
Sir, you visit to Dhanbad also.
Yes, Dhanbad, I am already invited for your program. This
Yes, sir.
And I am going
Please.
to come.
You are most welcome, sir.
Yes.
With your team.
Yes, sir. Dr. Shehnaz, over to you, please. She's not there.
But anybody can take.
Dr. Nigat, are you there?
Dr. Nigat is there. Yeah.
Yes.
Yes,
Yep.
Nigat.
Will you please take this question?
Okay, sure. What is the rule about the death certificate? And in case of stillbirth, how to record?
So as far as death certificate is concerned, if you are sure of cause of death, then in death certificate you will have to mention cause of death also. So just like this, a patient so and so aged, residing at, expired at, on, in our hospital during treatment, cause of death, whichever the death may be. If you are not sure of cause of death, and if you have advised postmortem examination, then you have to mention in that certificate also postmortem examination was advised to know exact cause of death. Because many a time certificate is needed for final ritual also. In few of the center it is very much required. So you have to issue a death certificate. Death certificate doesn't mean that it should always be issued for some medical legal purpose only. Because we have to issue death certificate and we have to register death with respective authority within 21 days, just I mentioned prior also.
Okay.
And as far as stillbirth is concerned, same way. We have to register stillbirth in prescribed form, that is form 3, to appropriate authority.
Okay. Thank you. Thank you.
Dr. Shashibala, are you there? Or anybody else can take it if Shashi ma'am is not there?
No, this
Hello?
taken.
Yes, ma'am.
This question has been taken. This question has been taken.
I have asked this question already.
Yes, it is taken.
Okay, now, Dr. Nivedita, this is for you.
Okay, so sometimes what happens is that we have written something in the records and then we realize that, okay, this patient might create a problem later and there may be a need for altering something in the record to make it more favorable, doctor favorable. Can one alter the records?
Usually, we should not alter record because in court we lose credibility. But if at all we have to alter or edit rather, then we have to stick and we can write new thing whichever thing we have to add. But that very information which we have stuck up should be readable. So what was written prior and now what is written. So that way only we can alter. Otherwise, court doesn't give us permit to alter record.
Right.
So now we are at the end. And if anybody has any question that they think is not covered, they can ask.
I would like to ask just one question. Since we were doing the placenta adherence syndrome, and I would like to know what is the protocol for if there's a death on table.
So in any death on table, not for placenta aggregata.
No, just for this. Yeah.
For any on death table, if we are sure of cause of death, then we can issue certificate, death certificate. And if we are not sure of cause of death, we can submit that patient for postmortem examination. Many times relatives are not willing to go for postmortem examination. So, and they are ready to give in a writing that we are not willing to go for postmortem examination. But in this type of situation, this type of writing doesn't give you immunity in court of law. So, if you are not sure of cause of death, always advise postmortem examination in this type of situation. Death on table is a very vast topic for discussion. It needs separate lecture or even panel for death on table. But as far as certification is concerned, we have to take care of this.
Thank you. Thank you, sir.
And
Sir, I have one question.
Yes.
Dr. Gayatri, I would like to ask a question.
Yes, madam. Welcome.
Sir, I would like to know that regarding the anesthesiologist, they sometimes it would be asked by the court that what is their whether they are postgraduate or not. Is it mandatory to have postgraduate or only
Yes, sir.
some years of experience under a qualified professional medical college or which was designated as a medical college under him for past 30 years or more than 10 years? Is it, what is the exact things, if you can say me?
So as
can
per
explain
MCI
it?
and NMC guideline, any person who has a qualification, diploma or degree, postgraduate in anesthesia is labeled as a anesthesiologist, and they should be registered in respective state council also. And with whenever they are having postgraduate degree or diploma, they should be having additional qualification, additional registration in medical council. So this is very required thing as far as experience is concerned, because in few of the states in past, few people were trained or they were given training for some anesthesia, for say for example tubal ligation, or in remote places cesarean section. So if there is a circular on part of government and government has given a training and issue a certificate, they are in a M panel of anesthesiologists, then they are saved in court of law if at all they have to face this type of litigation. So
Sir, but before 2012, even the RMP, our RMP was also, they are doing gynecological practices. They were labeled
Abhi
as
allowed nahi hai. Abhi allowed nahi hai.
now it is not allowed, but earlier before 2010-12 it was allowed.
There are situations in this situation, whenever we are facing litigation, it always some questions are taken into consideration. Where you practice, with which resources you are practicing. Say for example, if you are practicing in very remote area and where no gynecologist is available, even MBBS registered medical practitioner can also do cesarean section. It was given in one of the case in Supreme Court also. So, the situations are taken into consideration. But if gynecologists are available nearby, then gynecologists should be involved. Same way anesthesia. If nearby anesthesiologists are available, then it is always preferred to involve recognized anesthesiologist. Otherwise, in any given emergency, say for example, it is an acute emergency, and to reach anesthesiologist, it is time consuming and no time is for treating surgeon. Then in this situation, person can go for. But whatever we do, we should be in a position to justify our position, our role, our action in court of law. So by documentation, you should prove in court of law that it was acute emergency, it was immediate necessary to go for surgery, and no qualified anesthesiologists were available, and this trained person was available there to assist as far as taking care of patient is concerned. So in which situation you are working or you have worked are taken into consideration in court of law. But it is always preferred if anesthesiologist or any person required, qualified person, is available nearby, we should involve them.
Thank you, sir. Thank you, sir.
Can I
Thank you
ask
for
a
the
question?
Yes. And this is
Dr.
my
Niggar?
humble appeal to endorse my candidature for post of President Foxy election year 2024.
Thank you, sir. Sure, sir. It would
Can
be
I have a
my
question?
Sir,
And
Dr. Nighat wanted a question, sir.
I
Yes,
just want, out of the curiosity, like you said, the maintenance of records for MTP and like 5 years, and then indoors 7 years, and so many the period you said. Suppose the cases are going on in the court and certain natural calamity.
So in case of litigation, till final disposal of case, we have to preserve record.
No, I mean to say if the records get destroyed in a natural calamity like the floods or fire or anything, what is
But you just I mentioned also, whatever you say in court of law, you should be in a position to justify. If you can prove that all the records were destroyed in fire or due to flood or due to earthquake or whichever the natural calamity, or we may call it vis major. In legal term, it is called vis major, which is beyond control of anybody. Then it is pardoned in court of law. But you will have to prove in court of law that they were destroyed in this type of situation.
Okay, thank you. Thank you so much. Thank you so much.
So,
Thank you, sir. Now, after sir, I would like to make my appeal.
So it is appeal on part of Dr. Asha Jain, madam also. I would love to take it. She is going to contest for post of Food, Drug and Medico Surgical Equipment Committee, FOXY. She is very deserving candidate for the same post. And you all are requested, the other president and secretary of respective society, to nominate her candidature at the time of nomination and to vote for her at the time of voting. Of course, as far as nomination part is concerned, you will have to go with two nominations, one for Asha Jain madam for post of chairperson and one for me for post of President FOXY.
It is our pleasure, sir. It is sure, sir. It is our pleasure.
Yes. So it is my humble appeal to support Asha Jain madam also.
Sir, I would like to say something, sir.
Yes.
Hello.
Yes, madam.
Sir, can you give me any previous court order that some experienced anesthesia in a person experienced in anesthesia can be they have won the case. So do you have some documentation regarding that in any state?
I have no such case, but we can.
Ma'am, actually, I'll tell you the reverse. I'll tell you a reverse in Bokaro. A very senior gynecologist got a patient, underwent C-section under epidural anesthesia by a trained, so-called trained, I won't say anesthetist, also trained technician. And the patient collapsed on the OT table. Finally, she died after a month. A court case was filed and the surgeon had to pay a huge amount of money because the anesthetist was not a qualified anesthetist.
But that in this case he is a technician, but the doctor is an MBBS doctor, but with 30 years experience under some medical colleges, professions, like under professors of medical college designated.
मैम डाइकोटोमी चलता है गवर्नमेंट में आप जस्ट डॉक्टर्स को ले लेते हैं 3 महीना का ट्रेनिंग करवा करके दे आर वर्किंग एज एनेस्थेटिस्ट इन गवर्नमेंट सेटअप दे आर डूइंग लाइगेशंस सब जगह हो रहे हैं इवन इन बोकारो सदर हॉस्पिटल एंड ऑल इट्स टेकिंग प्लेस बट इन अ प्राइवेट प्रैक्टिस दे आर नॉट अलाउइंग इट मैम
one thing I would like to tell you, in Chhattisgarh there was one MD doctor, MD gynecologist. He was in a government setup. He was given 3 months of anesthesia training. Then he would give spinal and then he would do the cesarean. And once one patient died and he was in jail for 3 years.
Correct.
So let us not take that risk. जानबूझ के हम मतलब हाथ क्यों जलाएं होम करते हुए?
नहीं, right.
Really avoid that.
Suppose the case was earlier case more than 15 years old.
Doesn't matter, ma'am. That doctor is in his 50s. He had been doing that for years together.
नहीं
वो नहीं करना है.
डॉक्टर आशा
प्राइवेट में नहीं कर सकते आप और वो तो गवर्नमेंट में किया था तब भी अंदर हो गया.
नहीं गायत्री मैडम इज मेंशनिंग बिफोर 15 years where
anesthetists were not
available.
तब तो ठीक है मैम, तब तो ठीक है.
In those situations, in court of law, it will be taken into consideration that whatever.
But not today, na sir. Not today.
Not today. Today, I just mentioned, if anesthesiologist is available nearby, you cannot entertain any other person to go for anesthesia. So it is always advisable, but if it is talk of before 15 years where anesthesiologists were not easily available, so whatever you did in good faith of patient is always pardoned in court of law, but you will have to prove in court of law that in which situation you took that decision and how you proceed with the case accordingly.
हाँ,
you.
ये
Thank
भी
you.
क्वेश्चन है
Thank you.
यदि एनास्थेटिस्ट सपोज कि नहीं एमबीबीएस डॉक्टर यदि सिजेरियन करती है तो
नहीं, just
हाँ,
like
हाँ,
MBBS
वही चीज तो है,
doctor
वही
can
तो
go
चीज
for
है ना।
anesthesia if he is trained in some institution, just Nivedita
अभी तो
mentioned that
गवर्नमेंट ट्रेन कर रही है
for,
सर मेडिकल
for
कॉलेजेस में
3
ना।
months or whichever period.
हाँ
So
कर रही है गवर्नमेंट 6 मंथ्स
they are allowed, but many in so many states they are in panel of anesthesiologists. Government gives them certificate to go for anesthesia.
Sir, even
only
in government setups,
only
in government setup, only in government setup.
Government
gives them the certificate to only do cases in
nowadays this is the rule, but earlier before 13-14 years earlier the anesthetist qualified anesthesiologist was very rare.
Yes. So
Yes,
just I
ma'am.
mentioned that.
हाँ सर ने वही तो बोला कि अगर आप दिखा दीजिए आपके रिकॉर्ड्स में that you could not get a qualified anesthetist for the emergency case and you got a person who was trained, a doctor who was trained in anesthesia to do the case, आप कोर्ट ऑफ लॉ में बच जाते हैं। आपको वो रिकॉर्ड पे रखना है बस।
I already mentioned.
That I have thank you, sir.
That is
Thank you. But I'm not visible in the video.
No, but you are very much audible.
I'm
Very clearly you are audible, madam.
नहीं मैम आप पीछे हैं, आप थोड़ा सामने आइए, आप थोड़ा सामने आइए। एक्चुअली आपका बैकग्राउंड वर्चुअल बैकग्राउंड दिख रहा है, आप थोड़ा सामने आइए तो आप देखिए।
मैं दिख रही हूँ अभी?
नहीं
एकदम अब देख रहे हैं मुझे?
नहीं भाई नहीं मैम आप बहुत पीछे हैं, आप बहुत पीछे हैं।
Chaliye.
Okay,
Sir,
can we-
we
can
have
we-
actually crossed a lot of time.
Yes.
Yeah,
So,
can we take a leave now?
oh yes.
So that
oh,
is
yes.
what, so I would
Oh,
like
yes.
to officially thank everyone who's here, all the faculty, chairpersons, guest of honor. Ushanath ma'am, you're still there. Would you like to say a few words before we end?
बैकग्राउंड देख रहा है मेरा फोटो क्या हो गया?
Any expert comments from Ushanath madam? And
मैम
then we-
आप अपना वाईफाई कान से ये हटा दीजिए मैम।
And then we
You're not
will.
audible.
Madam, we are not. You are not audible, madam.
मैम का वो
There is
problem.
some connectivity issue.
Yeah,
also.
उषा मैम, ईयरफोन हटा दीजिए, आपकी
मैम, अब-
आवाज नहीं आ रही है। आप ईयरफोन हटा दीजिए, अब डायरेक्ट
ईयरफोन
बोलिए
हटा-
तो आवाज आएगी।
हाँ
No, still there is some problem.
There is a problem with the net, I think. मैम ईयरफोन को पूरा डिस्कनेक्ट कर दीजिए, लैपटॉप से हटा दीजिए। नहीं सुनाई दे।
No
नहीं
issue.
पा रही हैं, कुछ बोल नहीं पा रही हैं। So we can, I think, end.
Sir, I think we can end
So
it.
we can conclude.
So Nilesh ji, धन्यवाद. Thank you, Corona. Thank you, all respected faculty, for giving so much of precious time in the festival season. You've spent 3 hours here. Accept a heartfelt thanks. Namaskar. Thank you. See you on some other forum again.
Thank
Please
you,
don't
and all the
forget
best.
Patel sir
All
and
the best.
Thank you.
All the best. All the best. All the
for
best.
giving me this platform.
I'm ending the session.
Thank you.
Love you all.